Good evening, everybody, and welcome to another evening with a webinar hosted by neoss Implants. For those who don't know me, my name is Lloyd Searson. I'm one of the directors here at the London Centre of Prosthodontics. I also hold a consultant post at King's College Hospital in London. Tonight is an exciting night. We are going to look at restoring implants at a single platform level. This lecture will appeal to the whole team of the implant world. It'll appeal to users of implants that over the years have got frustrated with companies bringing out new components, changing the platform, and in changing the platform, they've had to change all their inventory. It will appeal to dentists who are interested in getting into the implant world, who've been on a course and have found, again, the same conditions where there are so many components, so frustrating, they've never really been able to take that step into the implant world. It'll appeal to the auxiliary staff, the nurses, the people who do the procurement. It'll also appeal very much to corporates who have multiple dental practices and how to rationalize their inventory to satisfy all patient demands and all their conditions. I've been involved with the neoss implants since 2004. I was probably the first UK dentist to place the neoss implant and restore them. And today it's still the primary implant system we use in the practice. This is not a new one solution. The concept of one platform really started back from the inception of the neoss implant with the co-founders Neil Meredith and Fredrik Engman. Fredrik will be joining us at the Q&A later on. And on that note, during the lecture, if there's any pressing questions, by all means, type them into your Q&A section. And hopefully at the end, we'll be able to go through some of the questions. Fredrik and myself and Kavit will be able to hopefully answer some of your questions. Without further ado, it gives me great pleasure to introduce the main speaker this evening, Dr. Kavit Shah. Fortunately, I've known Kavit for many years. He's also a senior partner here in the London Centre of Prosthodontics. And he's going to share with us his experience. He is a highly trained clinician. He has lectured nationally and international on both the restorative and the prosthetic side of implants. And there's no one better to be able to share his thoughts on restoring implants and his experience with the neoss system. So on that note, I'm going to introduce Dr. Kavit Shah.
Thank you, Lloyd. And I will now start to share my screen. Fantastic. So it's a real great pleasure to be here, albeit virtually. I know in better times to come, we shall meet again together face to face. But what has really amazed me is the fact that this virtual platform has allowed so many of us to come together this evening. And I'm honored that you're all here with me. As you all know, the topic of my presentation this evening is restoring dental implants, excellence with simplicity. Now, the focus is going to be on the restorative interface, or the restorative platform, as we call it. But before I wanted to proceed, I want to stress that I have no commercial affiliation with neoss other than receiving a stipend for this evening's presentation. The clinical choices that we've made that I showed to you are based on my time in practice using multiple different implant systems and distilling down what I think is really important. I use the neoss implant system out of choice, and I will try and show you the reasons behind this. So that being said, the learning outcomes, what I hope to present to you by the end of this evening, is that I want you to appreciate the benefits of having a single restorative platform system across an entire implant range. I want to try and highlight the significant advantages that offers us in practice and hopefully you in your various offices, but the fact that having a single restorative platform doesn't actually limit the restorative options that are available to you. And I'm going to talk about soft tissue integration. I'm going to talk about preservation of marginal bone. I'm going to talk about precision of fit and strength in function. Now, before I start, let me just give you a little bit of a background about where I and us at the practice are coming from. Both Lloyd and myself are trained prosthodontists. We're involved in clinical practice predominantly. We're not researchers, and I'm indebted to those who do research in topics in implant dentistry because your data allows me to change or modify the way I treat patients to make things more effective and more predictable. So we're predominantly in a practice setting, and this lecture is all going to be hopefully practice driven. But we also teach, and we teach graduates on the placement and restoration of dental implants. And that's one of the major eye-openers behind why we make some of these selections. Through the 25 years or so that we've been looking after and maintaining implants at the practice, we have used a number of different systems. And what this has allowed us is to see, treat, and manage complications. And that's one of the main reasons behind a lot of the protocols and choices that we make. The complications that we see have allowed us to modify our protocols and procedures to hopefully try and make things a little bit more predictable. And throughout the course of the evening, I'm going to try and show you some of these things. So I think before we go to the future or the present day and talk about where we are in the current time with implant dentistry, it's really important to look to where it came from, where the whole beginnings began. Professor Brunnemark was a pioneer, but above all else, he was a researcher and a scientist. He stumbled upon the concept of osseointegration, and he developed an implant system. But he didn't develop an implant system and then advocate its use in patients. What he perceived was a problem. He perceived a problem where patients suffered with mobile dentures, particularly in the mandible, that it impacted their psychological status and it impacted them socially. And he realized that his scientific discovery with the use of dental implants could anchor these prostheses into their mouths. And so what he did was he provided clinicians with a solution to a problem. Now, there were very specific aspects regarding his implant, his original implant. The restorative platform, or the hex, was not designed to be used for any anti-rotation. It was purely designed to place the implant into the bone. And therefore, these implants were designed predominantly to restore fully and partially dentate jaws, so large edentulous spans. The implant itself was a machine surface, and therefore it was designed to be used using a delayed protocol with prolonged healing. And the specific design of the platform in itself was somewhat associated with the actual milling protocols that were available at the time to machine these implants. And here you can see one of the early Brunnemark prostheses in the mandible. And what's interesting is that in the early days, a lot of their prostheses were opposing removable dentures. And so the loading protocols that they were faced with are very different to the single units that we restore at the moment. Now, the whole system was engineered and designed with failure in mind. The component that attached onto the implant, which was at the bone level, was a pre-manufactured machine transmucosal abutment. You can see that on the top right. And that abutment itself had predetermined emergence profile, precision of fit, and it was manufactured in titanium. And the abutment was screwed in with a hex. The prosthesis was then screwed onto the abutment with a much smaller prosthetic screw. And you can see clearly the thread pattern inside the top of the hex. And what that meant was the whole system was designed with the prosthetic screw failure as the predominant cause of failure, either loosening or fracture, but it was very easily retrievable. So based on those early stages of the development of the Brunnemark treatment and implant concept, they arrived at some criteria in terms of success or survival with implant treatment. And we're all very much aware of these criteria. They've been published for many years, and they're still predominantly being used as a surrogate measure of success for treatment. But two of the interesting things, I guess, firstly, is that they still, at that time, they considered progressive bone loss of up to 2.2 millimeters as being a surviving prosthesis. And secondly, they had survival rates of around about 80% at 10 years. Now, we have a number of patients at the practice with those original Brunnemark external hex machine surface implants. And we've maintained them for many years. And the majority of these patients with these implants demonstrated excellent stable crestal bone levels with very little progressive bone loss, excellent soft tissue health. But what we did see over time was we see deterioration of the prosthesis with predominantly chipping, wear, and fracture of the veneering material. And this has been published extensively in the literature at the moment. Now, the whole concept of the screw within a screw geometry was that the manufactured component, the transmucosal abutment, had a very precise precision fit onto the flat-to-flat hex connection of the implant. And in this focus view of that radiograph, you can see the precision fit of that TMA abutment. But what you can also see on this image is the fact that the prosthesis, which was delivered on top, had a degree of misfit. And this is because the original prosthesis was manufactured using the old casting methods. At that time, that was the technology which was available. But that misfit was at the soft tissue, above the soft tissue level, and any precision, lack of precision, was focused on the small prosthetic screw. However, all of these prostheses being screw retained, it's very easy for us to access the screws and remove them. And therefore, throughout the course of time, we could rehabilitate these patients again. And this patient was re-restored with a screw-retained prosthesis with a milled titanium bar, in this case, screwed straight down to fixture head with the new generation of abutment screws. And so this demonstrates really what implantology is all about, and that is the maintenance of patients throughout the course of time. Now, criteria for success have changed. And here you can see an array of excellent researchers who have reevaluated what is defined as success. And one thing we know is that survival rates of the implants themselves have substantially improved. On the right-hand side, you can see two neoss implants. The implant which is being placed with the gold implant inserter was the original bimodal implant, and that was a low surface roughness implant. And you can see that the reduced wettability of the surface. The implant on the right is I say newer, but it has been neoss's surface for a long, long time now. And it's a sandblasted large grit acid etch surface, which is electrochemically modified for increased wettability. If you look at the graphs on the right, you can see that both implants demonstrate exceptionally high survival rates. The blue lines show you implant placement in pristine bone. The red lines show you the survival of implants placed into grafted bone, be it in the sinus or with GBR procedures. And what's obvious there, which we all know, is that these enhanced surface modifications on implants allow these implants to have excellent survival rates, irrespective of bone quality. Now, before we divulge onto the actual restorative platform, what is really important, take-home message here, is the fact that the neoss implant has a roughened surface in the threaded part of the implant, but the collar, the smooth, unthreaded collar, is a low rough surface collar. And this for us is essential. This is one of the main reasons why we place these implants, and that's because it allows us the flexibility to place the implants at crestal level or at tissue level, or in situations where there may be modified ridge anatomy. We're not overly concerned if a certain aspect of that flange is not totally housed within the bone because it is low rough surface and it's not threaded. Now, it goes without saying that implants therefore have an exceptionally high survival rate, but what we are now judged against as clinicians providing implant dentistry in the 21st century is we're judged against ultimate aesthetics in terms of white and pink aesthetic scores, and the ability for our prosthesis, which is delivered on top of the implant, to blend in seamlessly with what biology has already set about for us. And this is a massively big ask. As you all know, all of you who have been restoring and treating implant patients know that this is a big ask. So here you have a patient which we've treated at the practice at a 15-year recall. And what you can see here are two single implant crowns, cement retained crowns, on two central incisors. They're cement retained at this point because we didn't have the technology for angle correction screws. Wherever possible now, our main prerogative is to try and screw retain prostheses wherever we can. If you look at the radiographic level, you can see that both of these crowns were restored onto two straight neoss implants. These implants have the 4mm restorative interface platform, and there are 4mm diameter implants. Now, one of the points that Lloyd's already stressed in the introduction, what I want to bring to you as a take home is that connection and that 4mm restorative platform, that one platform has remained unchanged since the outset of this implant system, which I'm not sure if there's any other systems available on the market that can say that they've had this right the way through. And this is really important from a maintenance standpoint when you're looking after patients for a very, very long time. And if you look at the crestal bone levels, these sorts of minor crestal bone remodeling, but excellent bone stability is what we see routinely every day, day in, day out with our implant patients in practice. Now, the restorative interface or the restorative platform is not just that point where the abutment attaches onto the implant. It will impact on the crestal bone around the fixture head, and it will impact the soft tissue health and stability around the prosthesis. So what we're talking about this evening is this zone here and how this makes such a big impact. So David Cochrane's group in 2017 provided a very, very nice review paper on the implant abutment connections available. And they classified them as either having internal or external connections and having either butt joint connections or conical connections. They further went on to talk about having implants with a tissue level interface, where the interface is high up in the tissues, and likewise having platform switching, where the abutment is of a much smaller diameter than the implant itself, and so there's a horizontal offset. Now, in their paper, they also talked about desirable features which they wanted from an implant abutment interface or a restorative platform. They wanted to minimize the degree of bone loss or remodeling at the interface. They wanted an interface that provided a seal against bacterial contamination. They wanted an interface that would transfer any occlusal stresses along the body of the implant, i.e. away from the screw and along the entire body and not focused on the crest. They wanted to minimize the incidence of abutment screw loosening, which is a nuisance complication. And they wanted a connection that would make restorative stages and componentry and connections easy. This was their wish list, which I think is very, very sensible and very pragmatic. Now, from what we've done at the practice, all the patients we've looked after, all the cases we've rehabilitated, and the students we've taught, we've identified problems from restoring dental implants. And these problems, I've sort of outlined a few of these today here for you, one of which is the complexity of procedures, protocols, and components. Very often we come across systems with very large manuals with so many different components, so many different options. And as you all know, as clinicians, if we are given multiple options under a high stress environment when we're working, it's very difficult to find yourself making the right choice. And that's even if you're experienced. If you're a novice in implant dentistry, having multiple options makes the whole thing even more confusing. There is a big issue with seating of components onto implants, and not only seating, but the ability to verify precision of fit. And verification of precision of fit is critical because a misfit will result in implications with crestal bone loss, it will result in implications with soft tissue health, and it will result in implications with technical complications, screw loosening, fracture of materials. So we want a system where we can verify and guarantee passive, accurate fit. We talk about clinically relevant crestal bone loss because the key point here is clinically relevant, because every single implant system available on the market today, placed in the wrong situation by the wrong pair of hands with the wrong treatment plan, will experience crestal bone remodeling or loss. Now, the key here is that that bone loss, if it has a clinical implication, if it's progressive and results in disease, or if it results in soft tissue recession, which affects the pink aesthetic score, that's a problem. And that's what I'm talking about here. We really want a system where we can access and retrieve everything that we've placed to manage complications easily. Technical complications and biological complications affect implants all the time and at a very high incidence. And I'll talk to you about that throughout the course of my presentation. And it's really important that we talk about this. And the last one is implant fracture. It's a rare, but it is a complication, and the one we least want to experience, either during placement or under load. So based on that problem list, we wanted to write down a design solution wish list that we would like out of an implant system. And this is why we have almost exclusively used neoss as an implant system at the practice for over 10 years. And I will talk to you about each one individually throughout the course of the presentation. The solutions are having a single restorative platform, having a flat-to-flat self-locating connection, having a connection which is tight and is maintained tight by the high clamping force with an implant abutment screw, having a system with a restorative connection and platform that allows us to switch platforms where we need to. We know that commercially pure titanium is a tried and tested implant material with excellent success rates. So we want to be able to use this material for our implants, but still not compromise on strength. And we want to be able to provide long-term maintenance easily. And that means that by having a system which has an unchanged platform, connection, and screw throughout its advent, allows us to very easily manage these patients. This means that a patient that Lloyd maybe treated 20 years ago, who comes to see me as an emergency today or tomorrow, and I know it's a neoss implant system, my anxiety level drops substantially because I have no problems. I know the screw, I know the connection. I can't say this hand on heart for a lot of implant systems today because the goalpost has changed so often, even within the same manufacturer. So this brings us on to what you've all seen throughout the course of the run-up to this webinar, which is the one connection, the one platform smart prosthetics system. And what that means is that there is one restorative platform and one connection across an entire range of implants, be it straight, tapered, or edge. And it is the same connection irrespective of the implant diameter. And this has a number of significant advantages. The first is that in the surgical kit, the implant driver or inserter is the same irrespective of which implant is being placed. And this is a massive impact for not only you as a clinician, but also your nursing staff. There is a single abutment screw and a single abutment screw screwdriver with a given torque, which is the same. And that's also a huge benefit for us in a high stress situation. But also what's really important is there's a very reduced kit. Here you can see the single kit, the one kit. That kit you can see in this image is both the restorative and the surgical kit together. If you wanted to distillate out the surgical kit, all you need is the driver and the torque wrench. Now, like us, I'm sure some of you actually operate a referral practice where you send patients back to the referring doctor for restorations. Well, it's very easy to provide these doctors with the torque wrench and the driver at very reduced cost, and they've got all they need to manage the patients. The other really nice and elegant thing is the implant systems themselves are packaged, the implant is packaged with the healing abutments and this cover screw in the kit. Those healing abutments fit across any implant that is used, across the entire range. It is the same healing abutment and it comes in two heights. And I'll talk to you about the really nice and elegant aspects about those healing abutments as I go through the presentation. So I hope you can appreciate here how simplicity really does impact us at a clinical setting. Having a universal connection across an implant range limits components. It provides us with a universal driver, an abutment screw, a torque value, and above all else, it reduces inventory. But what's more important than all of this is the fact that it reduces the risk of human error. Frank Renard in 2017 produced a really nice publication looking at human factors as the primary cause of complications in implant dentistry. And this is nothing new. This is also seen in the medical field when you look at work by Atul Gawande on surgery in the medical profession. Human error is one of the main driving forces behind iatrogenic problems and complications. When you look at Frank Renard's paper, he talks about advanced tasks and complex procedures as being high stress and high error, missing equipment, unfamiliar equipment and complicated equipment protocols generate high stress, high failure, and inexperienced staff and staff who may not be aware of certain kits and protocols. And when you take all of this, having a system which is simple significantly reduces the risk of human error and reduces the stress in the environment. So that's really important. But what you don't want is a system that is simple yet limits your options. And I'll show you that it doesn't. So when we go through the entire setup, and this is a very summarized version of it, you can see, I'll just get my laser pointer up so you can actually see here. So here you have the open tray pickup impression coping. There's also a closed tray version. The open tray impression coping is packaged with the implant analog in the kit. It is the same impression coping irrespective of the implant that is used. You then have digital solutions. You have the universal scan body or the scan peg within the healing abutment, which is now available. And these fit irrespective of the implant system. What's really nice and elegant about the scan peg healing abutment setup is that once the healing abutment is placed onto the implant, it does not need to be removed during the impression stage, and it will only be removed when we actually fabricate the prosthesis. And so all you do is you insert the scan peg, and recent data which has come out of the University of Bern shows that both of these digital solutions offer similar accuracy to conventional impression techniques with polyether impressions. You have the ability to screw straight down to fixture head, whether it's a single unit with an engaging component, but more importantly, with multiple units. And because of this design configuration of the multi-unit abutments, you can restore implants straight to fixture head, whether they are up to 40 degrees offset on angle. And the system also allows for CAD/CAM titanium frameworks, chrome cobalt frameworks, but also zirconia. And what you can see from the image on the right is you can see that the zirconia has a titanium interface. And that is really important for us because we don't want zirconia directly into the implant itself, nor do we want the abutment screw torquing down onto the zirconia because that increases the risk of fracture. Now, the only caveat to this entire setup is the 3.25 implant, which is available in neoss. And this implant is the only implant that has different componentry. It's very easily highlighted in blue. Now, the reason I put this as a caveat is this is a highly specialized implant for high-risk situations where there's extremely reduced bone volume, width, adjacent teeth. And this is for the advanced user, but it's very easy to identify. So here you have a situation with a missing upper premolar. On the left here, you can see the peak healing abutment, and you can see the tissue health around this healing abutment. And if you look at the healing abutment configurations, they come in two heights, either a 5 or a 3 millimeter, and you have a variation of emergence profile, which you can use for molars. Now, the key aspect of this is the fact that the retaining screw is totally separate to the healing abutment itself. This means that I can modify the height of these healing abutments, I can change the emergence profile, I can totally customize them, and then insert the retaining screw and screw them in. This isn't possible with one-piece healing abutments because if you adjust the top of it, you will destroy the hex driver connection. And I know myself, and I know a lot of you, it's frustrating when you have to try and modify, you don't have enough height and you have to butcher the prosthesis, the provisional prosthesis, try and make it fit. This is the kind of soft tissue health that we routinely see on this healing abutment. And on the right here, you can see the pickup impression coping, the neoss open tray impression coping. In practice, wherever possible, we use an open tray impression technique because we know from the evidence in the literature that this is more accurate, the precision of the coping and the impression is more accurate, and the specific design of this impression coping very nicely resists not only rotation, but vertical movement. And with the flat to flat connection here, you can see the precision of fit of the two components. You can verify this very easily. And what also is very nice is this impression coping is self-seating in that retaining pin will not engage the threads in the implant or tighten down until that impression coping is fully seated. There is a closed tray option available, and this involves the pickup of a basket. So there's a very precise click when you insert that back into the implant. And there you can see the precise fit within the impression itself and the health and precision and beauty of the restoration. This is a metal occlusal surface, and you may think I'm a brute coming from London doing this, but this is an extreme parafunctional patient. This patient had fractured teeth, and so I don't want chipping or fracture. I could have used zirconia, but I was much more confident with metal. This is another case. It's a case where we have different clinical settings. Different sites need different implants. The posterior sites have increased width and reduced height. And here we want to place wider diameter implants, possibly shorter. In the premolar area, you have a reduced width, but you have length. So you want to use a narrower implant. You can see here the healing abutments, which have the more acute emergence profile. And here you can see the soft tissue health. Irrespective of which implants used, we use the same impression copings. And you can see those little plastic sleeves on top. This is one of my favorite aspects of these impression copings, is the fact that these sleeves come packaged. And so when you seat the open tray impression, the sleeves very easily protrude through the impression, and you don't have to spend time, stress, and tension trying to locate the head of these impression copings. So it's a nice little elegant touch. On the radiograph here, you can see the excellent accuracy of fit of these impression copings onto the flat-to-flat connection. And you can also see clearly here the platform switch, which is available when you increase the diameter of those implants. And you can also see the very nice stable crestal bone levels. We then go on with multiple implant systems to fabricate verification beams, which allow us to verify the accuracy of our working casts with radiographs and then record a jaw relation. My technician, now more often than not, even if I take an analog impression, will digitize it using these universal scan bodies, but he doesn't have the stress or anxiety of thinking about which body will fit onto which implant because it's the same platform. So he has the same healing abutment, same analog or replica, and the same scan body. We then CAD design a metal framework with an anatomical cutback, and this is sent to ARC in Sweden for milling. And then we get sent back the metal framework with an anatomical cutback and proper support for ceramic. And here you see the finished result with the veneered restoration, linked crown, screw retained straight down to fixture head. Anatomical support for ceramic is critical because we know that chipping is one of the main complications. Another situation where you have a molar and a premolar site. In this case, we have the risk of anatomy of the mental nerve and the ID canal in the premolar site. And so we want to use a tapered implant with an apex that stays away from anatomy. In the molar site, we want to use a wider diameter implant. Again, you see the very nice soft tissue health, the same open tray impression copings, but what you see here is the shorter ones. So neoss have a slightly shorter open tray impression coping available for those problem access areas in molar sites. And this allows us to finish a very nice workflow. So I did touch on the digital workflow, and here you have a situation with the universal scan body used with an iTero intraoral scanner. The case is then passed on to my technician for CAD design, and here you can see the full contour wax up, digital wax up, and the anatomical cutback for the metal framework with proper support for ceramic. And there you have the final finished crown in situ. So we have options for fully analog, fully digital workflow, flexible workflow, the use of various different materials. Now, this is a topic which I hear about all the time, and it's crestal bone remodeling has been one of the main driving forces behind implant restorative platform design for quite a few years. And it's used as a reason for advocating the use of specific implants and implant systems. So before we talk about crestal bone remodeling, I want to briefly touch on the concept of biologic width, because this is where it's all related. Tomasi produced a very nice research article. It was a study in humans where implants were placed with a special pin, which allows him to use a soft tissue trephine at various time points around that pin to look at the development of the peri-implant mucosa. Now, what you can see on the chart here, the burgundy color represents junctional epithelium and the blue represents connective tissue. Now, what happens is over time and with 12 weeks of healing and maturation, the connective tissue height increases up to a height of 1 millimeter. And we know this from teeth and the work by Garguglio. And then you have a junctional epithelium attachment. But what's really important is if you look at the final dimension over time and with healing, it averages around the 3 millimeter mark. And this is the golden number, the 3 millimeter rule. So let's look at the connective tissue attachment around an implant. The fibers are either parallel or perpendicular to the implant and or the abutment. And the circular fibers are more dominant around the abutment collar. But what's really important is that these connective tissue fibers don't actually attach onto the implant or the abutment. They only provide a mechanical barrier, a tight ring seal barrier, and they prevent the apical migration of the epithelium. So therefore, what this is telling you is actually it is the connective tissue and the connective tissue orientation that prevents the apical migration of your peri-implant mucosa, and therefore dictates the extent of bone loss. And so on the basis of this, the greater the amount of soft tissue you have around your implant head, the more bone you'll preserve. And the more under-contoured your restoration prosthesis is in the first 2 to 3 millimeters following the emergence from the head of the implant, the greater the soft tissue thickness and the more bone you preserve. And so what I'm telling you is that crestal bone remodeling is a physiological process associated with biologic width and soft tissue thickness. Yes, there may be implications with implant design, surface treatment, connections, but the main protocols or factors that have been shown to make a significant contributing impact on it is to ensure that you have a suitable thickness of greater than or equal to 3 millimeters of tissue above the implant. You want to have abutment geometry which is under-contoured or concave to increase the volume of tissue. And the only real one which relates to the diameter is to have a platform offset. So platform switching was developed by Lazara in 2006. And one common misconception is that to have a platform switch, you need a conical connection. Well, that's just not true, because you can have a platform switch, as you can see with the neoss system, with a straight connection. Now, what platform switching does is it just places the offset or the connection away from the crestal bone. And what this does is it reduces the amount of bone loss, and it brings the bone to implant contact closer to the restorative interface. And the degree of marginal bone resorption is actually inversely linked to the amount of offset. And we see this with the neoss implant system itself. So this is a really important slide. What you can see on the left is the implant itself with the smooth, low roughness collar. And as you move up the implant diameters, because the restorative platform is identical, it's a 4 millimeter platform, you start to get an increasing amount of offset or platform switching. And this directly relates to reduced crestal bone remodeling. But I guess a take-home message from all of this is that we're looking at dimensions from 0.2 to about 0.8 millimeters. Now, there's not many clinicians among us here that can calibrate radiographs and look at situations and measure this degree of tolerance. So yes, this is in theory important, but really from a practical perspective, if you have enough soft tissue, it doesn't matter. This is a really nice paper by German Gallucci's group looking at the emergence profile. And they used 2 different healing abutment emergence profiles. And what they found was that the under-contoured, the concave emergence profile of the componentry resulted in substantially less crestal bone remodeling than the actual wider emergence profile. So it's the emergence profile of your restorations and the pressure you place. So taking all that on board, when we talk about crestal bone remodeling, if you put the implant in the right place, you respect anatomical landmarks, and here you can see a neoss implant being placed by the driver. You place the head of the implant at least 3 millimeters apical to where you want the soft tissue to finish. So you preserve that 3 millimeter golden height. And you place the implant preferentially towards the palate. You means you maximize the bone, you preserve the biology, and you get the result. If you don't have that soft tissue, here's a situation of a resorbing central incisor with a hopeless prognosis, a high scallop gingival tissue type, a high risk case. Here we opted for an early delayed approach as per the team in Bern by Danny Boozer. We looked at early implant placement with contour bone augmentation to account for crestal bone loss. And after a period of healing, we take a fixture head impression, precision of fit of the impression coping. And here you can see the finished result with very nice, stable, soft tissue and very nice, stable crestal bone, even though this is a platform-matched system. And that's because we've preserved biology. A similar case, in this case, we adopted an immediate placement protocol because we had a good thickness of buccal bone plate. We had a compromised central incisor. The implant was placed, immediate placement, but in this case, we adopted a submerged approach. We buried the implant. We carried out bone augmentation into the gap. After a healing period, we uncover it and place the peak healing abutment. We take an impression. Here you can see abundance of very nice soft tissue. And here you can see the restoration at delivery and the very nice stable crestal bone. But there's no point in me showing you this at delivery. What you want to see is time and how things change over time. And here you can see the pre-op situation, the situation at delivery, and the 10-year recall. And if I preserve nature and respect biology, my platform and connection has little impact on the health rather than biology itself. And so my choice of restorative platform, my choice of connection, my choice of implant is based on prosthetic convenience. A couple more cases, 2 premolars adjacent to each other with 2 screw-retained implant crowns independent of each other, and you can see a very nice soft tissue health and crestal bone stability. What's really interesting in this case was that the implants were placed at 2 different time points. The second premolar was placed first, and then at a later date, the first premolar tooth was extracted and that implant was placed. A similar situation of an upper first premolar. This is a screw-retained crown placed onto an implant which was inserted as part of an immediate placement protocol. If you look at the soft tissue integration and health on a focus view, I don't think you can argue with that from a clinically relevant standpoint. And if you look at the crestal bone underneath, this is the kind of stability of crestal bone we see even on the platform matched setup. Another case of a single central incisor. This is the routine health we see around the connection. This is the kind of development of the soft tissue emergence and support we see. This is the final prosthesis in place. But what you want to see is what this looks like over time. And here you can see the 10-year recall and review of the radiographs. And you know that's 10 years later because you can see the increased radio density of the crestal bone around that implant. And this is something we see routinely, and it does not impact on the health of the soft tissues. So I often hear about conical connections as being what we must use now clinically. And there are a few reasons why we don't use them in practice routinely. Firstly, it's very difficult to screw straight down to fixture head for multiple units. And so therefore you have to use an intermediate abutment. This means you have more components. With a conical connection, there is also a vertical misfit, which means that when you torque the abutment into place using the abutment screw, as you torque the screw, the cone of the abutment will seep further into the implant. And this results in potentially loss of preload. It produces an outward tensile stress onto the wall of the implant. And it is very difficult to verify the accuracy of fit of components onto the implant in the laboratory on the analog and in the mouth. It is a misconception that conical connections do not have a microgap. They all have microgaps of varying degrees. And also what we do know from the literature now is that with commercially pure titanium, conical connection systems may have an increased propensity for fracture. And this isn't just anecdotal, this is shown in the evidence. This is a very nice review by Blum, looking at various different types of implant system with different conical connections. There's no standardization. The cone angles vary. The amount of contact between the cone and the implant wall varies. And what they showed very nicely is that the microgap was evident even when the implant was unloaded. But under load, that microgap got enhanced. And that was because of increased wear and rotational movement and pivoting of the cone abutment inside the implant. And the ultimate problem, which you see, is then potentially wall fracture due to these outside tensile forces. And this is an Astrotech implant with a wall fracture. So when you look at the flat to flat versus the cone connection, the reason why we like the flat to flat is that you have this precision fit of seating, which you can verify clinically and in the laboratory. When the abutment screw is torqued, the flat connection generates a compressive stress onto the implant body, whereas a cone connection will generate an outward tensile stress. And when you look at the load, that video you can see on the bottom right is a flat-to-flat neoss connection under 150 Newton centimeters of force, and you can see the tight connection there. The image on the top is another manufacturer's cone connection. You can see the pivoting and rocking of the cone inside the implant. And these are things that, from a long-term standpoint point of view, we're not totally comfortable with. But the game changer has to be not only the implant, not only the abutment, but the abutment screw. When you talk about a restorative platform, you have to talk about these three together. And you want a screw that generates an extremely high clamping force at a given torque. And the neoss abutment screw has some very nice concepts to it. It's a titanium screw, but it has a fused gold coating, which reduces friction. And therefore, it generates exceptionally high preload. But when it's designed, and we need to think about the design of abutment screw fracture, the screw is designed to fracture high up here, where there's a change in diameter. And that is high up, almost outside the body of the implant itself. So retrievability is very good. You look at strength of connection. Strength of connection is critical, not only under load, but firstly under placement, because when we place our implants, we're now with immediate implant placement, immediate loading, we want very high insertion torques. So we want to be able to generate these torques without worrying about fracture of the implant. With the neoss implant connection, you can see that on insertion, most of the stress is a compressive stress within the body wall. There's no outward stress that you see with some of these other designs of implant abutment connection. And the image here below you can see is of a different manufacturer's implant that actually fractured during insertion. This was a narrow platform implant, and you can see that how thin the outer wall was and the outward tensile stress which resulted in the fracture. But it's not just during placement. You have to remember that when you load implants in function, they don't just rock from side to side or up and down. Implants rotate under masticatory forces, so you need this anti-rotation. And that strength of the neoss connection gives us the confidence to use them very predictably in molar sites. And here you can see a whole array of different molar situations where I've used the wider diameter implants. I've got a thicker wall because of the platform offset, but I've also got a platform switch, which means that I maintain crestal bone right up to the collar of the implant. And on the case below, you can see a situation where we use the tapered implant because we've got anatomical constraints down here with the lingual fossa, but I still got a very nice thick collar. Here you can see the radiographic view of the implant restored, and clinically we get very nice soft tissue health, emergence profile, and stability. But above all else, the buck stops with us as clinicians, because it's occlusion and the control of occlusal forces is what relates to load on the implants. So ultimately, you may choose whatever implant system you want, you may choose whatever connection or platform, but you must control the forces. And so we take a lot of time controlling contacts, size of occlusal tables, and cantilevers. We use devices such as face bows for the larger cases, and we provide patients with occlusal splint appliances to protect restorations. So let's just talk about complications here for a minute, because this relates to retrievability. This is a very nice review from Peterson's group, which looked at complications. Now, I want to draw your attention to, they divided papers that were published before the year 2000 and after the year 2000. And I want to draw your attention to those published after the year 2000, because that's relating to modern day implant dentistry. And if you look at prosthesis survival, it's very high, in the high 90s. But look at the complications. The complications range from 16 to 53%. And full arch prostheses have complication rates of up to 50%, which is huge. We see complications every day in practice. We see screw loosening and screw fracture of these small prosthetic screws, which some of our patients still have. Thankfully, with the neoss Crystallock screws, we don't see it as much. We see chipping and wear of ceramic. We see fracture of frameworks. And we also see peri-implant disease now, and peri-implantitis and progressive bone loss. And a lot of this progressive bone loss is either because there's not enough bone around the implants, And we get sent these patients all the time where we have to look at saving implants that have been placed elsewhere, and there's not been enough bone around the implant, but also because of cement extrusion. And so what this means is that we want to be able to screw retain all the time, every time, straight down to fixture head to reduce complexity. Now, one of the other big things that we need to think about going forward is that proximal contacts open up over time, and you get opening of contacts and you get the implications in terms of caries and periodontal disease. Opening of contacts can be seen as up to 50% in some of these studies, and they are a significant risk indicator for peri-implant mucositis and peri-implantitis. So that means we need to remove these restorations and redevelop these contacts. And so you must have screw retention if you want to be able to do this easily. And so if we can't screw retain because of implant angle, we now have the ability to use these new angle correction screws. And the neoss IGO angle correction screw is a very nice screw because firstly, we can torque it down to the full torque, which is the same as the crystal lock screw. It allows us to modify the angle as opposed to the implant angle. And what's really nice from a long-term maintenance perspective is the fact that if I go and look back at one of Lloyd's cases 10 years later, I'll know whether it's an angle correction or not because the top of the IGO screw is blue as opposed to gold with the abutment screw. And here you can see a very nice case which has been elegantly restored. It's an upper premolar tooth, lovely soft tissue health from the peak healing abutment. And here you see a porcelain fused to metal angle correction screw crown, and this is the kind of soft tissue health that we see. Maximize the bone volume, increase the soft tissue thickness, use an appropriate system, screw retain where possible, and that's where you get the predictability. So to finish, I'm just going to take you through a final case, a slightly more complicated case. Here is a case where we have a large anterior edentulous span. In this case, we placed 4 implants. These were placed using an immediate placement protocol with concomitant bone augmentation into the gap and soft tissue augmentation. After healing, we're taking an open tray fixture head impression using the neoss open tray impression copings. You can see here the beautiful plastic sleeves, which offer us that lovely reassurance when we see the impression. You can see the head of those impression copings, which offers stability within the impression. And in this case, I've used what I would consider an anatomical verification beam. And I'll show you exactly why I did this for this patient, because it's a very complex occlusion. I've used the titanium temporary cylinders, the neoss titanium temporary cylinders, which here you can see the precision of passive fit on the analogs in the laboratory. And that's really easy to see. I can then seat that in the mouth. And when I take the radiograph, I can see the precision of fit, or I can notice any misfit. Now here, it's not really misfits because I've only placed a single retaining screw, but you can really nicely see the fact that if it's not seated, it's easy to see. And it also demonstrates the really nice soft tissue, the bone health around those implants. Now, once we verified the cast, in this case, we did an analog setup and a try-in of an acrylic prosthesis. This is a provisional. We can allow this to be used over a period of time. The patient can wear it. And once we're happy and comfortable, this can be duplicated using milling techniques. And then we send a copy mill framework to the neoss facility in Ark in Sweden. They carry out a milled framework for us, anatomical cutback for ceramic. And here you see the complicated occlusion. This was a crossbite. Now this gentleman is 70 years old. He's not interested in correcting what he's lived with for 70 years. So I have to adapt to what he's lived with and provide him with stability. I could have used zirconia, but in this situation, I felt more comfortable with porcelain fused to metal. So we've got an extensive metal framework. We fuse the ceramic on top, and here you have a screw retained prosthesis straight to fixture head. And this is the prosthesis. The final prosthesis is delivery, very nice soft tissue health, nice stability, and nice prosthetic integration. And so finally, to summarize, why have we made the choice to use the neoss restorative platform and the neoss system in our practice? Because it offers us simplicity of a single connection and a restorative platform across an entire implant range. And that impacts us, our dental nursing staff, and our laboratory technicians. As I've shown you today, we have a comprehensive availability of options when we restore these implants. We can very easily verify and maintain precision of fit. We have the confidence of strength. We know from restoring and maintaining patients that crestal bone levels are stable and are implicated by what we do rather than what we use. And it is very easy to retrieve these restorations when we need them for maintenance because they are screw retained. With that, I'd like to thank you for your time. I'm now going to stop sharing my screen so that we can take part in the Q&A. Okay. There we go.
Kavit, thank you very much for a very logical clinical approach to what some people will find a very daunting area, but you've actually summarized it very nicely on that single concept. We have a number of questions that have come in through the talk, and without further ado, I'm going to introduce Fredrik Engman. Fredrik is currently the CTO and the co-founder of neoss. He's an engineer by background. And Fredrik, I'll start with you actually. The first question has come from someone asking, the neoss implant is commercially pure titanium. Most other companies will use a alloyed implant for strength. Are you comfortable with the strength, stability, and clinical performance of a commercially pure titanium implant?
Absolutely, and you know, just because it's a commercially grade 4, you know, there are many options there in terms of strength, and we use especially annealed and Calderon titanium, which makes it almost as strong as an alloy. So there's not a big difference there, but it's also in terms of the design. If you have a poor design of the implant, it does not work with titanium. Titanium is really sensible for design features, so that's one part of it. But we also know that it's not only the strength of the implant in itself; it's actually the pillar that helps. So the connection and the screw is part of the strength. So first of all, yeah, we were able to use a really strong grade 4, and we did not want to have any compromise. There's so much data on the grade 4 when we started, and you remember we started over 20 years ago, and I think history has shown that the clinical performance of our implants is fantastic. So it was the right choice, and there's no need, if you can design in the right way, to have anything than a grade 4 commercially pure. So
thank you. Kavit, a number of people have come in about platform switching. It's obviously still quite a hot topic out there. One of the questions is, do you find any situation where platform switching could be detrimental?
So it's a really, really good and interesting question. So platform switching itself, if you use an appropriate implant system where you can seek components easily and you can verify accuracy of fit of restorations, therefore in itself, there's no reason why it should be detrimental. The problem arises is where a platform switch compromises on the strength of the abutment, which then inserts into the implant. So in order to get that offset or that platform switch, you, for narrower diameter implants, 4 or 3.5 millimeter implants, in order to get that offset, you're using a substantially narrower abutment into the implant itself. And if it's in a high load situation, I would be a little bit concerned about the strength of the abutment into the implant itself, because it's much narrower. And therefore, that's why when you look at the neoss system, for the smaller diameter implants, it's a platform match. From a health perspective and a biology perspective, there's no doubt, and this is shown in the literature, that platform switching will offset the micro gap. So it does increase the predictability of bone level up to the head of the implant, and it will potentially increase the volume of connective tissue around there. Does that have any clinical relevance? I think, as I said, if you have good volume of soft tissue and good bone around your implant in the first place, maybe not so much.
Okay, thank you very much. Coming back to Fredrik, It does seem, one of the questions, it does seem such a very logical approach that neoss brought out. Why haven't other companies done a similar concept?
Well, the one static platform, it is, there's, to start a new implant system, as we did a long time ago now, you do have the opportunity to put all the good things together, and you may have to make some real decisions. The first one is to make a flat connection. It minimizes stresses enormously. You drive the stresses to the screw, and it means that you actually take away the tensile stresses. And if you do that, then as long as you can have your minimum diameter implant really strong, which we do, it's actually very strong. Then everything that is beyond in size, it just gets stronger. So if you optimize it for the weakest or smallest diameter implant, and you can have really high strength of that, then you can work on it. And that's what we started with. It was good to start with a blank sheet of paper and a head full of ideas. And also to know the material, as we discussed before. If you know how titanium works, and you can create a lot of preload, because again, it's not only the implant, it is the connection. So to capture a connection in as small space as possible, then you can create a one platform implant. And it is very difficult for a conical connection to have that because of the stresses that you cause, and also you have to have the knowledge about the material. So those are the two main things, I would say.
Yeah, one question has come in, someone asking, are you really saying to me there is one driver to put the implant in? And I'll answer that and say, yes, there is only one driver, regardless of what diameter implant you're using. So your auxiliary staff will find it a lot easier to use.
As I said, look, the only exception being the 3.25, but that it's bright blue in color, and so there is no risk of a mistake.
That's right. And to be honest, as you mentioned in your presentation, this is an implant for the exceptional case. And in all our years of using neoss, there's only been a handful of cases that I've used the 3.25. But I say more for the experienced user.
Advanced sites, advanced and experienced users. Yeah.
Kavit, someone's asking, how far off straight angle can you go with the Indigo angle corrected screw?
I will. So myself personally, wherever I place the implants, I will strive to go no further than 15 degrees, just from my own personal perspective. I think Fredrik can answer the maximum tolerance limits for the IGO screw. Fredrik.
It goes up to 25 degrees. So it's a big angulation.
And can you still get the same preload on the screws?
Yes, yeah, you get the same preload. It's the same surface coating, the same torque, and yeah. So we get the same very high preload.
Another question's coming for Kavit, asking, do you ever link your impression coping together, or do you find the necessity to do that?
So the evidence in the literature, whether or not to link, is not clear cut. You can find papers that prove either way. Personally, I know Lloyd, you don't link impression coatings at all. I'm very, very confident about the stability of that neoss open tray impression coating within the impression itself. And we use properly supported trays and proper impression material. But one of the critical factors is that you should dry those impression coatings very well so that the silicone or the polyether sticks to them, and then they should be cast in an appropriate fashion in the laboratory. And to date, we've not splintered any impression coatings. Not I haven't personally, and I haven't had any issues with passivity of fit. The issue, if you do splint them, is that you have to bear in mind that the material you splint them with has in itself dimensional change, whether it's acrylic or composite resin, and that may continue for up to 24 hours after you remove the impression. So this is something to bear in mind.
Fredrik, someone's asked, can you just go over the deformation zones and what importance they have from a stability point of view of the abutment?
Yeah, so if you the strength, as I said before, is the combination of a couple of things. But if you look at the connection between the abutment and the implant, is two things. It is the screw, how high preload you can achieve. Then the second is the mechanical locking of the connection. Simple things. Now, if we want to have avoid large movements, you have to make sure that you do not have small movements, because that's when the fretting starts. That's where the unscrewing starts. So this is why we have made the abutments larger than the implants. It is not by much, but you have this press fit to minimize any micro movements. So we have both the screw and the actual fit to the implant, and this is why the deformation zones play a role.
Okay, Kavit, someone's asked me in your clinical situations, which of the neoss implants do you prefer, the straight, tapered, or edge?
So my choice of implant system to date has been the straight or tapered, and my selection choice, whether it's straight or tapered, is based on my anatomical constraints. If I have anatomical factors, risk factors such as canals, lingual concavities, or buccal cord cavities, which mean that the straight implant will perforate and complicate grafting, I'll go for a tapered implant. Otherwise, I opt for the neoss straight implant. I have no problems achieving excellent primary stability with the existing neoss straight and or tapered implant. So today I haven't used the edge implant, but I know some great clinicians who've started using it and have had some exceptional results with it. The nice thing about the first and existing neoss implant with its double cutting face and its thread geometry means that you can get exceptional primary stability, irrespective of bone types. Fredrik, that was hats off to you, mate.
Thanks.
Another question, probably both of you can answer. So because of a flat to flat connection, is there a need for an abutment transmucosal abutment? I suppose the question really is direct to fixture level. Do you need to put a transmucosal abutment in?
Well, the data shows you don't. So that you have we know that if you don't have a stable soft tissue level, then you have a stable situation there. One of the underlying causes is that you're losing bone, and we have extremely little bone resorption over a long time. And we have many studies and also over 10 years. So this I think that's part of the proof, so to speak, for this. So I don't see a reason for that. So, but,
I think also because this implant, you've designed it in such a way, it can be a bone level implant and a soft tissue implant.
Yes, yeah.
So it gives you the versatility with the implant itself for both. Would you agree on that, Kavit?
Absolutely, Lloyd. So it's that versatility, but what's really, I think what's the game changer is the fact that, like, a number of different scenarios. So if we know that certain cases, and this is irrespective of which implant you use, there is over time, with age, with bone changes, bone remodels around implants, whatever you use. And if that remodeling is within a smooth, low roughness flange, I'm certainly much more comfortable. And the other situation is, for instance, when you use these implants in immediate placement situations, because using an immediate placement implant doesn't stop that remodeling process, and you can compensate for it with grafting and soft tissue grafting. But if you have the confidence of having a low roughness collar, you don't then have to compensate by sinking the implant so deep to try and make sure that it doesn't ever get exposed in bone. So these are factors which I think are so reassuring for me when I use it.
Yeah, and I just one of the when starting with this blank piece of paper and a little bit of knowledge, one of the main decisions was to have extremely smooth color. It is etched, but the roughness is very, very, very low for this very reason. And we can show now, we can see that more competitors are trying to mimic this approach. And as I said before, that the data is fantastic for us in relation to this.
I think that shows on the number of cases, very few cases, we've seen the practice of peri-implantitis because of smooth color, because we try and screw retain everything to avoid any use of excess cement. And the one thing nice about the whole system, as Kavit said, a patient can walk in tomorrow that had their implants put in 2004, 2005, and will know exactly what screw was used. If we need to take a new impression, it'll be the same impression. And there's not really any other implant system on the market at the moment. You can say that because nearly all the major competitors now have been changing something about the platform in the last 10, 15 years. And I know, speaking to dentists, they get very frustrated. They look at a case that comes in, and we've seen it ourselves with other systems. You're thinking, oh, the impression code was that, pre-2009, and it was a hexed or internal connection. And it is extremely frustrating. So from that concept, it makes, from a teaching perspective, from a practical perspective, such a versatile connection. And I have to congratulate Fredrik and Neil for their thoughts and development of this product, because it really has been a game changer within the whole implant world. I think you'd agree on that, Kavit.
Yeah, 100%. 100%. Unfortunately, there's not enough time in a web to go through all the different like the elegance of all the different components and where they can be applied in the restorative workflow. That's more for a long course, but there's so many other little intricate, elegant parts of it, Fredrik, which we find so useful.
Well, I think on that note, it's been a long evening. Kavit, thank you very much. Excellent presentation. As you'll see from the chats coming in, there's lots of congratulations. They thoroughly enjoyed the content. And to you, Fredrik, really historically for setting up and co-founding neoss, it has been a revelation. And for any of the participants, if they want to know more about neoss, please contact your local representative. They will give you more information. Look at the website. By all means, tune in to the next webinar, which is Chris Solano, who I know very well. He's a great lecturer, a big user of neoss implants, and his title is on the 30th of June. Again, no doubt you'll all be getting an email thing, and it's basically avoiding the hidden cost of implant dentistry. I look forward to participating on that. I'll listen to that one because Chris is a very good speaker and very enjoyable. So to everyone who's listened and will follow up on this, thank you very much for tuning in, and a very big thank you to both Kavit and Fredrik, and congratulations.
Thank you.
Thank you.
Good night all for hosting, and you, Kavit, for this.
Thank you. Bye-bye, everyone.
Thank you all. Thank you.
Bye-bye.